Next up will be a Zoom talk by Mike Venezia, who will talk about prone lateral approaches in complex spine surgery. So hopefully he's online.
Hey Chris, how are you? I hope everyone can hear me. Um, like you said, my name is Mike Venezia. Thanks again to Chris and Vdara for inviting me back. Really sad I can't be there this year. I think my wife talked to my partners, get me from going to Vegas. But anyways, I'm going to talk a little bit about prone lateral approaches in complex spine surgery. I'm an orthopedic spine surgeon in the Tampa Bay area at Ford Orthopaedic Institute. Some of my disclosures is that I do love prone lateral surgery. As well as I do teach it for a company and teach other surgeons this technique. As an overview, we're going to kind of go over some of the anatomy of lateral surgery, well, why we use lateral surgery, what are some of the risks, and the transition to prone lateral, why we're doing it, what's some of the evidence behind it. Also, some of the benefits and risks that we take on with prone surgery. So obviously, the lumbar spine approach is based on anatomy, based on the patient's pathology, their specific anatomy and accessibility to obtain a fusion, as well as surgeon's preference and training and the options available at your institution. And as we're all well aware of the lateral anatomy, this plays a big role into the treatment as well as the complications that we obtain in lateral surgery. Obviously, we're traversing the psoas major, which is the main hip flexor, and can be a main cause of some of the complications and side effects we see in lateral approaches. The lateral anatomy was well described by Uribe in 4 anatomical zones. And what he discussed about the zones is actually where the nerves lie and where's the most appropriate approaches for a lateral approach based on the level you're at. And we'll see from some data a little bit later on that this may adjust a little bit when we go to a prone positioning due to the actual positioning of the patient in the prone position. At the L4-5 level, we see that this junction of the nerves falls a little bit more ventral in a traditional lateral anatomy. And obviously, we're well aware that this was first described by Dr. Taylor and Dr. Pimenta in 2006 as an approach and technique for anterior lumbar interbody fusion from a retroperitoneal exposure. And why are we talking about types of exposure? Well, we know there's an increased global burden of disease with over 266 million individuals affected by lumbar degenerative disc disease. And an increase significantly in the actual amount of lumbar fusions that have happened over the last decade or so, as well as an increase in aggregate cost to our hospital system and burden on our healthcare. So we're trying to determine what's the best and our most appropriate approach for our patients that's going to provide longevity. And so what do we look for in a fusion? We obviously want to minimize risk. We want to maximize fusion. We want to maximize our alignment goals, as well as have the ability to complete our appropriate techniques, decompressions, osteotomies, whatever that may be, and reduce our incidence of revision rates. We want to minimize our pseudoarthrosis with maximization of our fusion and limit our subsidence. And we also want a lower cost of care. So what should our goals be from an MIS standpoint? Lateral is obviously thought of as a more MIS surgery, but I think I'll show you here and we'll argue that there may be some use in the prone position for open deformity surgery as well. But our goals should be the same as open surgery. They should be thoughtful and allow for the correction goals to be achieved no matter what our approach is. And a lot of the data has shown over the years that lateral fusions have a lower blood loss as well as a decreased hospital stay. And obviously if they have a lower blood loss and a decreased hospital stay, they're going to be up walking faster. And there's some unique advantages to the lateral approach, right? We avoid some of the complication risks of the traditional posterior lumbar interbody fusion or TLIF approaches with CSF leaks and trauma to the nerves and Campbell's triangle, as well as epidural fibrosis and arachnoiditis. We've also seen that there is a minimal disruption to the anatomy, such as the ALL, but still allows for segmental correction of our lordosis and allows for larger cage placements, which will theoretically lead to less subsidence as well as higher incidence of fusions. And in doing so and keeping our ligament ataxis, allows for us to use larger cages along the apophyseal ring and allows for indirect and foraminal decompression in the appropriately selected patients while maintaining the integrity of our ligaments. And in the right selected patient, indirect decompression is an appropriate option for some of these patients, but it's not the right option for all patients. And a unique option from the prone standpoint is that we're able to address all pathology, whether it be somebody that needs an open decompression or an indirect decompression from one single position without repositioning. And this kind of just shows that ligamentotaxis allowing for that indirect decompression in the right subselected patient. And Dr. Taylor put out a good paper on this, indicating the correct patients you should use to select and the incorrect patients for indirect decompression. And I'd argue that I think that the prone lateral allows us to include all of these patients because we can treat all of these individually with the appropriate care that they need. And here's some MRI showing that indirect decompression does work in the right selected patient, right? There's also some unique risks when we are talking about lateral surgery, right? Obviously, we're traversing through the psoas as we discussed, and so hip flexion weakness tends to be a common complication, as well as injury to the nerves in the lumbar plexus, as well as the more superficial nerves such as the genitofemoral nerve. Anterior thigh deficit maintains a common complication, as well as there is still an incidence somewhere between 3 and 5% of motor deficit based on the current studies. And these are thought to be led to two different mechanisms. One is indirect retraction time, where our neuromonitoring comes into play, as well as direct compression of the nerves themselves. Uribe put out a paper on vascular injury and showed that it was significantly less than ALIF procedures, but it still is a risk we have to consider in these patients. And obviously, effective neuromonitoring is an integral part of any lateral type surgery, whether you're doing it from the direct lateral position or the prone lateral position. The use of triggered EMG is helpful in determining where we're docking and where the nerves lie, but it only tells half the story. So we know that the use of SSEPs is very important, especially with the retraction and indirect compression on these nerves. So we've learned over the years that the saphenous nerve is the most sensitive nerve to monitor, especially at the L4-5 level when we're looking at the lumbar plexus anatomy. And this is highly effective due to it being the terminal branch of the femoral nerve. So what is prone lateral surgery, right? It's essentially trans-psoas surgery in the prone position. It allows for us to complete single position surgery in a more ergonomical setting, and allows us to perform open procedures in a way that we've been trained. We can place pedicle screws in the prone position. And it also allows for increased sagittal correction due to the positioning of the patient itself. Obviously, lateral decompression's not an ideal situation in my hands and most hands. There are a lot of people that are utilizing the direct lateral and placing screws in the lateral position, especially for those patients that are candidates for indirect decompression. But when we place these patients in the prone position, it gives us a more comfortable approach and allows us to perform all the procedures that we perform in a standard open patient if we need to. And this is sort of a picture showing the endoscope that I use as well during a lot of my surgeries that allows for a more ergonomical approach to the prone positioning. And the feasibility study of prone lateral was put out initially in 2020 by Godzik, and they looked at cadaveric as well as the early clinical experience of 12 patients and found this to be a reproducible and safe procedure, although it went through its iterations of figuring out the most effective ways to position these patients and how to do it safely and appropriately. And, for me, the switch really allowed for me to complete a single position surgery in a setting I was more comfortable doing, as well as lowering the OR time. I'm obviously in a very geriatric state. So that was an initial catalyst into looking into this procedure, but it really takes the variability out of the flips in your institution. And it's really a workhorse for almost all pathology other than obviously L5-S1 and some transitional L4-5. And segmental correction of lordosis, I think, is a really important component that it allows us to obtain with a lot more ease. And it can be incorporated into our larger deformity surgeries effectively as another tool in our toolbox. And the use of having a patient in the prone position, as you can see in the picture to the right here, myself and my resident are currently approaching the lumbar spine from the prone position, while my partner and his assistant are exposing the old hardware for a large reconstructive deformity surgery we were doing a few months ago. And there's some unique advantages to the prone position, right? It has the same advantages that we discussed of lateral surgery over traditional posterior surgery. But there's also some evidence that there's some increased retraction posteriorly of the femoral nerve that allows us to place our cages more posteriorly and allows us to dock more posteriorly in those further zones closer to the zone 3. And it also encourages more natural lordosis. and allows for better segmental correction. There's some evidence that it's at least as easy, if not easier, access to L4-5, and I think that has to do with both the coronal bending ability of our patients, as well as some of the retractors that we're using now. And it gives us that comfort of directly decompressing patients when we need to, and not having to worry about doing this from an indirect and coming back to operate on these patients again. Here's a patient of mine from last year or a few years ago that had adjacent segment failure with significant sagittal malalignment, underwent a multi-level prone lateral correction, and was able to meet all of his goals. And obviously, we know that there's a role of deformities, of MIS in deformity surgery, and Praveen created this great algorithm that looked at the different types of deformity patients and which ones are most appropriate to undergo a more minimally invasive style of correction. But the utilization of prone lateral allows us to include some of these more rigid spines and use lateral surgery as more of a tool in correcting these patients, and possibly including things like osteotomies if we need to. Hardeep Singh and Scott Mosey looked at the role for lateral fusion deformity surgery. And obviously we understand that there's unique risks that are associated with the lateral approach, but there has been shown to have decreased blood loss, as we've discussed, as well as neurologic risk and morbidity when these are done through a less invasive approach. And we can utilize techniques as ACRs or hyperlordotic cages if we need to, and the prone positioning for simultaneous access to allow us to approach the spine and save time and anesthetic time in these patients. And this can also be utilized in larger constructs as you get more comfortable with the positioning and the use of prone lateral. This was a patient of mine that I treated in the last few months that had a history of L2 to 5 prior fusion and progressive failure with coronal and sagittal imbalance. This was an elderly patient that I wanted to minimize time under anesthesia and avoid a PSO if possible. So we performed a hyperlordotic A-lift stage 1 with a 30-degree cage, and then ended up correcting the coronal plane with a L1-2 prone lateral while doing the posterior instrumentation. Now, what does the data show about prone lateral currently? The positioning of the femoral nerve was looked at, and this was an anatomic study that looked and found that the femoral nerve position was on average more posterior in the prone position than in the direct lateral position. And this is a consequence of how we position these patients and extend the hips to allow for posterior rollback of the psoas muscle. The positioning was also looked at here by the Brazilian Spine Study Group and found to have significantly increased lumbar lordosis as well as posterior retraction of the psoas muscle, which, as you can imagine, if you roll that psoas muscle posteriorly, the nerves will come along with it. And then this was a paper looking at the access to L4-5. And I don't think you can argue that it has significantly better access, but we do know that it's equivalent or possibly better. And I think that really just comes down to a combination of our techniques as well as the instrumentation that we have to utilize, as well as improved positional lordosis, as we're well aware. Now, sagittal correction is an important component of this, and this was a paper just looking at does approach matter when we're talking about sagittal correction, and this was looking at A-lift versus A-lift and lateral surgery versus T-lift and posterior-based surgery, and found that there was a significant improvement post-operatively in the patients from an anterior column with regards to sagittal correction. And we know that segmental lordosis is extremely important in our patients. This is a study out of Korea that looked at L4 to S1 lordosis divided over the L1 to S1 lordosis ratio. Those greater than 50% had a statistically significant decreased occurrence of adjacent segment disease. Again, this is delineated again and again in the literature that the more we can correct our segmental lordosis, the lower our incidence of adjacent segment disease is. Again, a paper by Chris Kepler looking at degenerative spondylolisthesis and segmental correction of these patients and a reduction in the rate of adjacent segment disease. This was a paper that came out in 2020 by Dr. Pimenta looking at a multi-center experience on the prone lateral approach. And these patients had a statistically significant increase in their lordosis, as well as, I think more importantly, when you look at the literature, they had a statistically significant decrease in the amount of patients that had lumbopelvic mismatches with PILs greater than 10 degrees, with a mean increase of 6.1 degrees, of segmental lordosis correction. But if you look over on the bottom right here, you can see that the number of patients that initially had a PIL mismatch of over 10 degrees went down significantly post-operatively. Again, another one of my patients that underwent a multi-level correction. And really, I think what's important to see here, and I put this arrow here for a talk with one of my partners who's very against MIS surgery, to show that all this correction was done before any bone work was needed to be done. And this was all positioning and the use of cages. And I think you can perform more goal-oriented surgery. Admittedly, I think that some of this comes down to the use of dual-bladed retractors that have multiple options on where we can dock our patients, but you can target specific goals intraoperatively and dock for placement of cages based on what you want to achieve, right? So obviously in an indirect decompression, you're going to give up some lordosis, but you're going to gain foraminal height when you with a more posterior based cage. But if you need to dock your cage more anteriorly for more lordosis correction, that's also an option. This is a patient of mine that had a prior lumbar fusion from L4 to S1 with a lumbar kyphosis at the upper lumbar spine, and had some collapse, as well as needed to have redistribution of their lordosis in the L3-4 level. So we docked our cage more posteriorly in the L3-4 level, and then we docked our cage more anteriorly in the L2-3 level in order to open that level up and correct that segmental kyphosis. And these are the final films from that patient. But so I think the take-home point here is that lateral fusions are another tool in our toolbox, and it can be utilized successfully to treat deformity, not only in an MIS standpoint, from an open standpoint. And the utilization of this in the prone position, I think, just adds to another tool that we have to treat these patients in the most appropriate patient-specific way. Obviously requires proper understanding of the spine, as well as the mechanics of your patient's pathology and their pain generators. And, I think indirect decompression has a role, but I think that patient selection is key here. And the use of prone positioning allows us to not just buttonhole us into a specific treatment. And I think this is just a further iteration of a tried and true technique with its own unique advantages that will help treat patients further. And thank you so much for your time. That's all I have. Again, sorry I couldn't be with you guys.